Good morning, welcome to the Festival Ideas. For those of you who've not been here before, welcome. For those of you who are returning, welcome back. So I want to welcome you to the James Burgess Lecture, which is funded by the largesse of the Burgess family. And we've got two eminent speakers here today. One is going to be talking about eyes, and one is going to be talking about the heart. So we have Richard Gale, who's internationally recognized as a expert in medical disease of the retina, and he practices in York and North Lincolnshire. He's a professor of ophthalmology at the Hull York Medical School, so he is local, and the University of York, and is honorary consultant medical ophthalmologist with York Teaching Hospital. And his interests are in the fields of medical disorders of the retina, in particular age-related macular degeneration, which you probably know as AMD. And in 2017, he was awarded Researcher of the Year by the National Institute for Health Research and the Royal College of Ophthalmologists. So he's at the helm also of the Yorkshire Macular Degeneration Fund, which is our charitable fund to support research into AMD. We also have, on the heart side, Dr. Ramesh Nadarajah, who is a National Institute of Health and Care Research academic clinical lecturer in cardiology and health data research, UK fellow at the Institute of Data Analytics and the Institute of Cardiovascular and Metabolic Medicine at the University of Leeds, which is quite a mouthful. So his research incorporates the use of large, routinely collected data sets, as does mine, so we might have something to chat about afterwards, in answer to clinical questions, and develop and validate prediction models, particularly in the area of atrial fibrillation, heart failure, and atrial fibrillation after stroke in particular. And he's now translating these prediction algorithms into clinical trials. His clinical interests are in prevention, early detection, and screening of renal metabolic disease. So what we're going to do is we're going to have about sort of 15, 16 minutes from each of our speakers. We're going to hopefully leave a good sort of 20 minutes at the end for your questions, okay? And then I'm going to give you some more instructions about how we're going to manage the question and answer session so that we all behave. But I'm going to hopefully give as much time as possible to get your questions in. Okay, so I'm going to start with Richard.
Good morning, everybody. Can you hear me? Great. So look, I've got some slides I'm going to go through here, but I appreciate there may be people in the audience who aren't able to see the slides, so I'm going to be talking through them and ensure you won't miss anything out in the information. Thank you very much, Tim, for the kind introduction. And really, I'm going to be talking about four main points. One, how we generally maintain the health of our eyes. Secondarily, I'm going to talk about three research areas which are really exciting and help protect our health of ourselves and our population. So I'll just move on, and here we are. So this is the first slide. So why am I particularly interested in eye health? Well, I'm putting up a slide now which ranks how people with eye disease view their disease compared with lots of other disease, cardiovascular disease, kidney disease, etc. And actually, they rank it very highly indeed. And that's actually not quite commonly known by many people, and indeed charity funding organisations. So it's really very important topic. And just a couple of facts: 2 million people in the UK are registered have visual acuity issues, and 1/3 of a million people are registered as sight impaired. And every 6 minutes, somebody begins to develop sight loss. And 1 in 5 of us will develop this at some stage. And age-related macular degeneration, I'll come on to in a moment, explains about half of the cause of visual loss in the UK. First point, maintaining vision health. I put up a carrot. What did our parents tell us? We must eat our carrots to help us see in the... Well, actually, we need our carrots to help us see altogether. So first point, we must have a balanced diet. We need the nutrients to help our eyes. And vitamin A is particularly important. No smoking. We all know this, don't we? So smoking is really important. Not smoking is really important to reduce inflammation within the eye that causes eye disease, and it is responsible for higher rates of blinding disorders. But sunlight does the same as well. And we should all be wearing our dark glasses, our UV glasses, when we're out, if we've got eye disease or not, when we're outside in the sunlight. And probably a really important message also is we should all attend routine and regularly to our opticians. So whether you're invited every year or 2 years, and you should mention if anybody in your family has an issue with eye disease. So just a general statement there. Now, I put up a mind map here of all the different areas of research that we're involved in. And in the center of that is the early detection of a condition called age-related macular degeneration. So I'm just going to talk a little bit about this. The retina is the back portion of our eye, a little bit like the film in the camera that develops the picture. And the macula is the very central part that gives us our best quality of vision for reading and recognizing faces. Now, unfortunately, in around 700,000 individuals in the UK, this area degenerates faster than we would normally anticipate. And essentially, there are two types of this. Something called dry, where there is loss of the light-sensitive cells, and about 1 in 10 people will get a severe form of this with a gap in the vision and a potentially blinding disorder. By that I mean unable to see the top part of the vision chart. And then secondarily, there's another type called wet, where there is formation of blood vessels. And this wet disorder comes on very quickly in one eye only, with a quarter of people getting it in the other eye within 3 years. And the difference with this wet disorder is there are treatments available. And those treatments available are, ready for this, injections into the eye. Now, what is the most effective way to prevent visual loss due to this age-related macular degeneration? I'll let you into a secret. I asked ChatGPT. And actually, ChatGPT confirmed what most of us think, that early detection and prevention is the #1 way of trying to reduce the burden of this disease, the blindness that causes it. But there's all sorts of other things, nutrition and diet that we've talked about, and not smoking. And indeed, maintaining cardiovascular health as well, we'll hear a little bit later about. So I've now put up a chart, and this is a graph, and it shows essentially 2 lines. Along the bottom is time, and we see a line that's going down, and that represents reduction in vision. And this is what happens with so-called natural history and age-related macular degeneration if we do nothing. And there's a line at the top which goes up a little bit and then flattens out over time. And that's what happens if we give these regular eye injection treatments, probably the most important graph of my career. And actually, I put a line on now, or an arrow on, is where we are detecting majority of people at the moment with significant visual loss. When they come to us, when people come to us, they've already halfway down the chart. But I want to make a case for detecting people much earlier in that disease when it first starts, because then we can maintain vision. Let's just talk a little bit about that. Now, of course, this is a partnership between many organizations, University of York, Medical School, National Institutes of Health Research, the government effectively, Macular Society, and many pharmaceutical industries who are also interested in supporting our mission. And very importantly indeed is the Yorkshire Macular Degeneration Research Fund. Just tell you a little bit about that. So this has been established for well over a year now with the aim of supporting research into macular degeneration. And I'm really proud to mention that Dame Judi Dench was made patron, or accepted to be patron, of the Eyesight Lost Fund. And that's really speaks to the weight of the burden of this disease that we're trying to help. And unfortunately, Dame Judi also suffers from macular degeneration. And she mentions how she's so pleased to accept being patroned to this organisation. This is a very kind letter that she wrote to us when we were able to approach her recently. And what this demonstrates is a unfortunately quite poor handwriting. She finds it difficult to write now. In fact, she can't read her scripts to act anymore. She has to learn them by heart. An example of the devastation of the disorder. So what are we going to do to change this? We're going to try and detect people earlier. And my ambition, and the ambition of many people, is to change policy within the government so that we effectively monitor people who may develop this and we catch it early. So instead of people coming to us when it's not quite too late, but they are suffering considerable visual loss, we want to actively find people and detect the disorder early on. And there's a number of criteria that need to be filled for screening. And these two researchers in 1968, the Wilson and Junger collaboration, really gave us 10 criteria which must be fulfilled. And actually the World Health Organization and the National Screening Council still use this now. It stood the test of time. So we'll just quickly go through some of these. So is age-related macular degeneration an important health problem? What do you think now I've told you? Yes? Of course it is. 67 million people in Europe are living with age-related macular degeneration. Why don't we know about this? Because we don't talk about eye disease. We talk about heart disease, we talk about cancer, we don't talk about eye disease enough. And this is predicted to rise significantly over time. Is there a suitable test or examination that can be used? Well, there is. And that suitable test is an eye scanner. And a little bit of a shimmy here onto the side. There's an appeal out for Anna the Scanner. We're trying to get Anna the Scanner, Fund 1, for the university to research, but I'll come back to that in a minute. So suitable test examination. And we were involved in a piece of work that showed that this particular high-resolution scanner of the macular area is much, much better than people reporting symptoms or using distortion lines on a grid. We've done that work. It was funded by the National Institute of Health Research. And in fact, the health economics that were done that sit behind it showed in this particular situation, it was very cost-effective to be able to use a scan to detect this macular degeneration in this particular circumstance in the second eye of somebody who's already developed it in one eye. So we followed these patients for another 5 years because we were very interested to see what was the comparison between early detected macular degeneration in the patient population in their second eye compared with their first eye. And we detected about 4 lines on the optician chart earlier, and even after 2 years of treatment, about 70% of people maintain the ability to drive. That's a huge change. So the next thing is, well, actually, is this test acceptable to our population? So if I invited people to come along to have a test, a scan of the back of their eye, every 3 or 4 months, would people actually come along? I don't know. Some people would. Some people, well, I've got a problem. I'm not going to go to this test. So actually, we've got a study to see whether it's acceptable to population. We have funding, and we've, in fact, enrolled about 130 individuals into a mock screening program. So some people come every year, and some people come every 3 months or so. And we're beginning to understand, or we will understand, if people will persist and adhere at least over a year with invitations to have these regular scans. And it's entirely delivered in the community into high street optometrists or community eye health centres. And they are in areas of higher economic, wealthy areas, but also we've reached out to areas where there's more socioeconomic deprivation to see if there's any differences there. Funded by Roche. So the next thing, is there an agreed policy on who to treat? Well, actually, NICE tell us that we can only treat people when they've lost a certain amount of vision. That seems perverse, doesn't it? So we're gathering the information. We're gathering the information to try and make the case that we can treat people earlier. And as the price of medications come down, the health economics begin to stack up for that. In fact, of that study I showed you a little bit earlier, we've shown that if we treat people earlier, we might be able to reduce the number of these regular eye injections that people get, which are required lifelong. Is the treatment accepted to our population? Do people come if we say you need a regular injection into your eye, more or less lifelong? Well, actually, people do come. And we've had a piece of work where we've had to define how people adhere to treatment. And indeed, we've put processes in to make sure that our treatment regimens are as friendly as possible so that people will come to these regular treatments. Have we got facilities for diagnosis and treatment? We have. We are so privileged in York to have taken action on macular degeneration. And actually most of our treatments, the 25,000 injections that are given per year for macular degeneration in our region, most of them are given in a football stadium. Not in the middle of the pitch, obviously, not in the stands, but in a purpose-built community eye centre where people can park, people can be dropped off, relatives can perhaps go and do the shopping at the same time. And this is a major advancement forward. And I'm just showing some pictures of this purpose-built and designed facility. So next of all, what is the cost? We're in the world now of cost and economics. We hear it all the time. So what is the cost of finding people earlier and treating earlier? Well, we're very pleased to have secured a grant from the National Institute of Health Research, a health technology assessment grant, to understand the health economics, the cost, the value to society, if we're going to produce a national screening program for early detection of macular degeneration. Because if the figures don't add up, it ain't going anywhere. So early detection that we'll do. And we've done a little bit of background work to this already. And of course, the case finding should be a continual process. So what we aim to deliver is a screening program. People with diabetes have a screening program for their eyes, and we hope to deliver a continual screening program for individuals who are most at risk of developing this wet age-related macular degeneration, where there's a proven treatment. If we catch it early, we can treat early, and we can give best outcomes. So I'm just going to quickly talk about two other areas of research which are quite interesting as well. And this is a huge mind map of individuals. This is how my brain feels on a Friday afternoon sometimes when I've been thinking about what we need to do. And actually, one of the things that I'd just like to quickly touch upon is that we still don't fully understand the biology of age-related macular degeneration. And with the very generous support of the Burgess Foundation, we've managed to support an MSc student who's looking into the biochemistry and the biology of individuals and trying to understand through chemicals and also through small RNA, a bit like DNA, our building blocks, why people might require more treatment compared with others. And this is very nascent early work at the moment. And just something else, the next part that we really need to be able to do as well is form a registry of everybody. This is my desire, a registry of everybody with age-related macular degeneration. We do this in diabetes. We do this, I'm sure, in heart disease. We do this in oncology, cancer, but we don't do it in certain aspects of eye disease as well. And I'd like to form a registry starting with York and Yorkshire of everybody with macular degeneration. That sounds really easy, but it's very complex. And those individuals, I'd like to try and collect information about their disease process and their imaging. And this is why we need Anna the scanner. Okay. So again, really very pleased to accept the very generous support of the foundation for supporting a PhD student who will begin to look into this. So last few moments, I think I'm up to my 15 minutes now. So it's a real privilege to work in the University of York, as all many academic institutions. And if you pop onto the website, the University of York is labelled as a university for public good. I can't think of any better good than the gift of sight. I really can't. You may disagree with me, Ramesh, when you talk about heart disease, but the gift of sight is very powerful indeed. And please help if you can fight sight loss. So I'm going to wrap up there, and thank you very much for your attention, and hand over to Tim. Thank you.
Okay, thanks very much, Richard. Okay, so we're just going to go straight on to talk number 2. I'm going to ask Ramesh, have you got your slides up? Yeah, we're going to find out. Okay. And over to hearts.
Thanks very much. It's delightful to be here. I'm actually based at the University of Leeds and Leeds Teaching Hospitals. You don't need to boo. I do. I used to live in Bootham, then I lived in Acomb, and now I live in a small village just outside York. So don't throw things. And actually, I work, and that was a fantastic talk by Professor Gale. So thank you very much, Professor Gale. And actually, I work for Professor Gale's brother, who's also Professor Gale. So they're a very clever family, and I'm hoping that in addition to the real important issue of trying to prevent sight loss, especially in older populations, I want to talk to you a little bit about one of the big heart problems in this country, globally, and especially in older populations as well, and that's atrial fibrillation. Does anybody here know what atrial fibrillation is before I carry on? Yeah, a few of you might know. A few of you might even have experienced atrial fibrillation, and many of you might know somebody with this condition. And what we want to speak about today is a little bit about what the disease is and what we're doing to try and detect it early. Again, this theme about detecting early, preventing bad things happening. So atrial fibrillation, as any of you who've met a heart doctor in the past will know, your heart's a bit like a house with a 2 up, 2 down. So you've got 2 bits at the top, blood comes in, 2 bits at the bottom, blood goes out. And atrial fibrillation tends to be a problem at the top of the heart. It makes the top of the heart, instead of beating nicely, it fibrillates, it beats in a very irregular way. And that makes the pumping of the blood through the heart less efficient. And it also means the blood is swirling around in a kind of inefficient fashion, and that causes problems down the line. So atrial fibrillation, as you look on the right-hand side of the screen, it causes symptoms. It makes people feel tired, breathless, gives people chest pain, lightheadedness, dizziness. They can feel the fact their heart is beating irregularly often. But actually, in many people, a third people up to, it causes no symptoms whatsoever. So the heart is doing that abnormal beating, and we see that heart doctors see it as this abnormality on the ECG in the bottom left-hand side of the screen. But many people have it and not know about it. Now, you might argue, if something is there but not causing me any symptoms, does it matter? But this does matter, because even if this condition, atrial fibrillation, which I'll call AF from now on, but if this condition AF is there but not causing you symptoms, it still can cause you problems. That irregularity of how the blood is flowing in the top part of the heart can make clots form. And when those clots shoot out the bottom of the heart, one of the main places they can go is the brain, and causing stroke, which everyone knows can be a terrible occurrence for an individual, for their family, and for their wider community. And because we know that, we did loads and loads of trials in the cardiology community where we looked at how can we reduce the amount of strokes that people with atrial fibrillation suffer from. And we've got loads of really useful tablets. Those are the tablets in the middle of the screen. Very well tolerated once a day or twice a day tablets that significantly reduce the risk of a stroke if you have AF. But this is a burgeoning problem. This is getting more common. So over the last 20 years, some of the work we did showed that the number of cases of AF detected every year, can anyone guess how much that's gone up by in the last 20 years? 5%, 10%? 100%, that's a lot, yeah. No, not quite that many, but 72%, yeah, 72%. So the number of cases diagnosed each year has gone up by 72% in the NHS in the last 20 years. And do you think AF is more or less common than breast cancer? More common? More or less common than lung cancer? More or less common than bowel cancer? More or less common than prostate cancer? No, yeah, more common than prostate cancer. How about more or less common than lung cancer plus breast cancer plus prostate cancer plus bowel cancer? More common, yeah. It's amazing, isn't it? Really very common. That's how many cases of AF are diagnosed each year, outdwarfs all of those cancers put together. And so we think about 1.5 million people across the UK currently have AF. And actually, amongst those 1.5 million people, we think about 300,000 people are living with AF without actually knowing it, without having been diagnosed, without suffering symptoms, but they do have this irregular heart rhythm. And we estimate about 15% of strokes every year happen because of this undiagnosed heart rhythm. So a bit like Professor Gale was saying earlier, we don't want to leave people to suffer with strokes. We want to get early, we want to catch this rhythm early, and we want to give people the treatments that we know work to prevent the stroke. So how are we going to go about doing this? So in recent years, loads and loads of pieces of hardware now exist that can help all of us detect this abnormal heart rhythm. You can get it picked up when you have your blood pressure checked. You can have it picked up on an ECG if you see a doctor for one of those. Do any of you have smartwatches? Or have a Fitbit or something like that? Yeah. So that can pick it up as well. That can give you a little beep telling you there's something not right with your heart rhythm. And there are also things that we can give you as heart doctors. We can give you patches, recorders, that can help you detect this heart rhythm. The problem is, if we gave these technologies to absolutely everyone, it wouldn't work very well. We wouldn't pick up many cases, and it would cost an awful lot of money. So no one's advising us to do that. And we also know that if we look more carefully, give somebody a monitor for longer, we'll pick up more of this rhythm, and we'll be able to get that treatment to them. So the difficulty is, who should we get these technologies to? How can we make that affordable for the NHS so we can bring this benefit to people in this country? So what we need to do is identify the people who probably have this heart rhythm but haven't been diagnosed yet. That's what we're trying to do, and that's one of the kind of programs of research we're currently doing. How can we find these people early, get the technologies to them, and get this disease diagnosed early, prevent strokes? So how are we going to go about finding people who've got this abnormal heart rhythm before they're diagnosed in routine care? Well, we can do clever things with AI on ECGs. Definitely we can do that. And that's a really good solution in some circumstances. But obviously, when we're walking around in the community, we don't necessarily have our ECG to hand, do we? One thing that we all do have, put your hand up if you have a GP. Yeah, I was thinking most people. Yeah, 98% of the population are registered with a GP. And as you know, when we register with a GP, we're registered when we're born, and we have all of our health problems. We see our doctors for lots of different things, and we have them all the way from cradle to grave. And that covers 98% of the UK population. So what we want to do is use that information in those records that we all have, they're there about all of us, to identify the people who are at risk of this heart rhythm, so we can get the diagnostics to them earlier. So we actually have done this research. We used 2 million anonymised records across primary care in the United Kingdom, and we used clever types of AI on that data to identify people who are higher risk and lower risk. This is all anonymised data. This is one of the great benefits of the NHS, is that we have this data across the whole country, and we can provide it in an anonymised fashion to researchers to try to do things that are helpful. And this tool we made, it's called Find AF, kind of makes sense, trying to find AF right, works. So we can use it across 100% of primary care records. It works very well. It's very accurate in its prediction, better than previous tools that were made. And importantly, when we think about if we want to use this in the UK, we want to use this in real people, we need to make sure that it worked equally well in younger people and older people, in men and women, and across the different ethnic groups that live in the United Kingdom. And we checked that, and it did work equally well in all those different populations. And on the right-hand side of the screen, what we did was we plotted out people who were higher risk and people who were lower risk. And as you can see, as time goes by, lots of people who are higher risk get diagnosed with this heart rhythm, but the people who are lower risk, they really don't. So we do think we're identifying the right population. And actually, what we did was we then exported this to lots of other countries. We said we can make it. We've made it in the UK, but does it work? Does it work globally? Because AF is important. It's very common in the UK. We have 1.5 million people in the UK with atrial fibrillation, but there's also about 65 other million people with this condition globally. So can we help not just the UK, but the whole world? And so we tested it not just in the UK, in Japan, in Israel, in China, in Canada, in Taiwan. And actually, we found it worked really well in all of these countries. And the last question was, great, you've done all this work using all this data, but this is just data, it's just numbers, isn't it? Does this actually help people? Can we put this into practice and actually improve our ability to identify AF, and can we get the people the right treatments? So with the British Heart Foundation, we've done a study, which has just finished actually, in Yorkshire, where we took people who have a primary care record, who would be eligible for one of these tablets if they were found to have AF, and we used the algorithm to identify higher risk people and lower risk people. And in this study, we sent people a text and a letter and said, would you like to have one of these tools sent to you, these diagnostic tools, handheld recorders? And people who said yes, this recorder was sent to their homes, and they checked their heart rhythm a few times a day for a few weeks to look if they had this abnormal heart rhythm or not. And we've actually done this study across 1,923 people in Yorkshire. And we're going to present these results at one of those, conferences where lots of doctors get together in a few months' time. But it works well. Basically, it identifies people who are high risk, and they have lots of atrial fibrillation that wasn't diagnosed before, that we can diagnose. And the people who are low risk, barely any of them had AF. So therefore, we think the algorithm works, Find AF works, and we think we can actually put this into practice, and we think we can actually get the right tools to the right people to get them diagnosed early and get them on the right treatments. And actually, this chap on the left-hand side of the screen, who's a retired member of our armed forces, he was a member of our study, a patient in our study, was diagnosed with the rhythm and is now on the right treatment to stop him having a stroke. And he's very happy about it, so he keeps telling all the newspapers about it, which is good, I guess. And obviously, we're trying to get people understand that this is an important problem, and this is something that we can actually improve upon. So we're talking lots to the media, to the BBC, to Sky, and to the Independent, etc., about how we can try and get this now from research into practice. And not only can we try and detect atrial fibrillation, AF, early, what we're also interested to know is, because this is becoming so much more common, right, which I said over the last 20 years, the number of cases has gone through the roof, can we do something about stopping it, not just detecting it and getting you on the right tablets, but actually can we stop people having this heart rhythm in the first place? And that's some more research we're doing with the British Heart Foundation, where we take individuals identified as higher risk by the algorithm, but who haven't yet got the heart rhythm, and can we do things to stop that happening? Can we try different treatments? Can we do certain scans? Can we check certain blood tests? A bit like Professor Gale was talking earlier with age-related macular degeneration. Can we do something similar with this heart condition? Can we identify people at risk and give them stuff to stop them ever having this problem in the first place? And that's hopefully something we'll be able to to bring forward in the future. And what we're doing in the next year is a bit like Professor Gale was talking about. We're trying to get this research into practice. So we're trying to put this clever AI algorithm into a platform, a kind of thing that can actually be put into records so that people can use it if they want. So doctors can use it to try and get the right test to the right people. But also, as Professor Gale said earlier, the NHS is not going to do this if it costs money rather than saves money. Fundamentally, that makes sense, right? We're in a public health system. What we do has to help people and has to be cost effective. And so some of the things we're doing now is working out the health economics, working out if we use this AI algorithm, if we get these test kits to the right people, can we actually detect the condition, stop strokes, and save people those terrible consequences, but also save the NHS and save the UK money. And we're doing that over the next year or so. So, short conclusion, this is a very common heart rhythm problem. It's becoming increasingly so, and it's causing lots of strokes. 15,000 strokes a year, 40 every single day. With the funding that we've been very fortunate to receive so far, we have actually been able to develop this AI algorithm and actually put it into primary care records in a research setting. And now what we want to do is we want to try and take this forward, get this into clinical practice, get doctors using it, get this benefit for patients. And anything that any of you could recommend to help us get that way, whether that be experience, whether that be advice, we'd be most grateful to receive. So thank you very much for having me this morning. Thank you for not booing or throwing stuff when I said I worked in Leeds. And I'm delighted to be able to take these questions alongside Professor Gale and Tim later. Thanks very much.
You might have seen the logo NIHR come up during these talks. So that is the research funding wing of the Department of Health, and I work for them. So I'm responsible for deciding who does and who does not get funded for this sort of research. So you can ask questions to any of us. I'm going to assume that you're going to push most of the questions towards Richard and Ramesh. Now, basic rules. So again, you do have a couple of eminent clinicians here, but they can only talk in generalities about these conditions, so please don't use this as an opportunity to have a consultation because they will not be able to answer those questions, okay? Could you also put your question in the form of a question rather than a statement and try to keep it sort of brief and to the point if you can. If you have 4 or 5 questions, pick your favorite, ask that one. If there's time, we'll come back to you again. And what I'll do is I'll take 2 or 3 questions from the audience and we'll try to address those, and then we'll go back out again. And we do have a roving mic, so before you ask your question, if you can just pause and wait for the mic to get to you. So it's up here. So we'll come down and find you. So any questions from the audience? So I'm going to do this roughly in the order in which you put up your hand. So I'm going to come down here first. So you just hang on for the microphone. Oh, could you pass it along? Can you pass that along? Thank you.
Thank you very much.
Okay.
Is it working?
I can hear you, but yeah.
That's all right then. It's a question regarding the AMD. Am I right in thinking that the research is not as far on as with the AF? Because with AF, you're talking about having identified high-risk and low-risk individuals, whereas the AMD, I didn't get information, which I may have just misunderstood, that you can actually identify high-risk individuals as to what are the real risks. You know, am I likely to get AMD? Is there anything that I can pinpoint that would help my optician pick it up?
Okay, so I'm just going to ask for one more question from the audience, and then we'll sort of address those. And hands. So sorry about this microphone. There's the lady in green at the back there. If we could get the microphone to you. Yeah, we could actually.
Thank you. I think my question might overlap a little bit with something that the lady just said, but I wondered the extent to which in your research you look at genetics, and that applies to both of you. because I think macular degeneration can run in families, as can AF. So I just wondered where that came.
Okay,
And
so, yeah.
Sorry.
Go on.
Also with the AF, do you look at the interrelationship, or is there any interrelationship with thyroid function?
Okay, so the general question about risk prediction. So, do you want to...
Both really good questions, and I perhaps didn't go into the details as much. Absolutely, there's risk stratification in terms of the degree and the extent of the age-related macular degeneration, which predicts this wet form and the likelihood of conversion or progression into the treatable form. So let me just rewind that a little bit. So 40,000 individuals will develop the wet form every year. This year, next year, the year afterwards. So that's what we're trying to prevent, 40,000 every year. Now, we know that if we screen everybody, all 700,000 individuals with age-related macular degeneration, that is a huge cost and burden to society, and it's very unlikely for policymakers, government, to be able to fund that. So we have to try and identify those who are most likely to convert, just as Ramesh said, the most likely to convert and progress, and therefore it seems as the right choice to have a regular scan. And yes, absolutely there is. And those characteristics are predominantly by the scan. Anna the scanner, remember Anna the scanner? Predominantly by this scan that we're doing at the back of the eye. And there's the very forms and shapes of the degeneration which helps make that prediction. Second part of the question, genetics. Yes, genetics do help us predict, particularly on chromosome 1, chromosome 10. There are certain mutations which make us much more likely to get age-related macular degeneration. And it may well be in the future that we are able to combine genetics with the so-called phenotype, how things look, to be able to make those predictions. However, the accessibility of the scan is fantastic. Most opticians have these scans now. They don't have research capabilities, but they have scans. But the genetics is sitting behind that. So great question. Yes, we do have risk stratification. Yes, we need to look at the correct people to make it the right thing to do to be able to screen. And yes, there are a number of different characteristics such as genetics which sit behind this.
Ramesh?
Yeah, I would only echo what Professor Gale says there. I think regarding specifically, we can find AF for AF better by incorporating genetic information. That is something that we've looked at with collaborators, and like most conditions, there is a component that's genetic and a component that is our lives and how we've lived and how long we've lived. And so that is something we'll look at in the future about incorporating genetic data in. A little bit following on from Professor Gale's comment in that there's a bit about rubber to road, right? So we don't all have our genetic data easily accessible, but we do all have electronic health records. So therefore, I think sometimes there's an idea about having the first filter, the first point of risk stratification, whether that be Anna the scanner, whether that be your electronic health record, to get into the system. And then after that, there can be further work about how can we even further risk stratify as we incorporate more information that's more expensive to get a hold of. And as the question about whether thyroid function is involved, yes, thyroid function is involved. Having too much thyroid is a well-known risk factor for the development of AF. And actually, thyroid dysfunction was one of the things that went into the algorithm itself.
Just as a follow-up to that, the general problem we have in this country is a lot of our health data is in different pots. So different people hold it in different data systems, and often the difficulty is linking those different databases up to be able to do this kind of research. And we're a little bit behind on genetics. So there are other countries, particularly the pesky Scandinavians, who seem to be ahead on all of these sorts of things, where they have much better data linkage, and they have genetic, health, social care data linked up in unified data sets. So sometimes what we need to do is sort of collaborate with those countries that have that sort of data to see if we can kind of corroborate what we're finding in the UK data. So if we could take to another couple of questions. We've got one down the front here.
Thank you. Another question for Professor Gale. I have 2 genes or genetic mutations that are associated with AMD. How likely is that there could be a causal factor? And should I be doing anything over and above the things that you've suggested, which I do, except I tend not to wear sunglasses. I wear a visor to keep the sun out of my eyes. But should I be wearing sunglasses as well?
Yeah, it's a really good. So a general answer to that question: if we know that there is a history or a risk, a higher risk, what should we be doing? So just to step back a little bit from this. So if one is affected by age-related macular degeneration, there's about a 20 to 30% chance you'll have a family member as well. So that's really important, and it's really important that you mention to your family members, not to worry them, not to panic them, but perhaps to, at their routine, normal eye test that we should all be taking, to mention that. Now, opticians should be asking about that anyway, but just to mention that as well, and then attention can be paid for that. So that's a really important aspect. In terms of general health, now, if one doesn't have age-related macular degeneration but has a risk for it, there's actually no great evidence of taking any particular vitamins or minerals reduces the chance of developing the later stages of the wet form. If somebody has macular degeneration of a more advanced stage, there is a particular advantage in doing that. And how do we know that? Because the studies, that good quality evidence has been done. So, first thing, maintain the nutrition of your eye. Protect your eye by doing that. And that's the 5 a day. Now, is there any evidence for taking the supplements if you haven't got this macular degeneration? No, there isn't. I take vitamins because I do a lot of exercise and I think it's the right thing for me to do. It's a personal choice. Okay, first thing, nutrition. Second thing is not to smoke. Did I say that? I think I said that. Please don't smoke. And no smoking, really important, not just for AF, but also for general life. Please don't smoke. Third thing, the UV. So what does UV do? So UV, it makes us feel good, doesn't it? It makes us feel great. We love being out in the sun. But we have to protect our eye health from the harmful UV rays. So there are 2 ways of doing it. Either the peak caps that's not coming straight in, or a nice pair of UV protective sunglasses. And I wear mine. I wear mine all the time when I'm out in the sun. It's just part of my normal life. In terms of having regular eye tests, and you should mention that you have a risk for this. And in some circumstances, some opticians do a regular eye scan. Sometimes you can pay for it. Sometimes it's £8 or £10, £25, £50, whatever, something like that. In my mind, that's a valuable thing to do. It is a valuable thing to do, but I appreciate not everybody has the means to do that, and that's why we're trying to change policy so everybody, whatever means you have, is able to access regular scans at the back of the eyes to detect it early.
Okay. Again, a couple more questions. One right in the middle there.
Thank you. Professor Gale started his talk talking about the benefits of health in maintaining good eye health. What about heart health? There have been studies related to gut and heart relationships, pathways. What could we be doing about prevention? I'm very much about prevention rather than cure. So it's very much about educating the public, I think, in ways that we can help ourselves.
Okay, so prevention question. I'm going to get one more question from the audience. And just gentleman at the back there.
To what extent do you need volunteers in your research, and do you get them?
Okay, so prevention and volunteers. Are you volunteering? Okay.
I think regarding prevention, these are, generally speaking, the things that prevent ill health across multiple domains, right? Across the eye, across the heart, across the lung, etc. So beyond regular exercise, and that doesn't mean you have to be an elite cyclist, it just means regularly walking even. There's actually quite a lot of data that shows if you walk 30 minutes a day for 4 to 5 days a week, that's better than any tablet I can give you, which is pretty impressive. Not smoking, eating healthily, incorporating those 5 a day, as Professor Gale mentioned, those are the kind of cornerstones of preventing ill health from the heart point of view, and of course avoiding smoking. If one does those things, you're most of the way there. Because there are some things we can change, such as those things, and there are some things we can't change, such as getting older, such as our genetics. At the moment, actually, there is some research into actually editing our genes, which we're not going to go into here. But those are the key prevention elements: regular exercise, eating well, not smoking, from a heart point of view. And to be honest, most heart diseases are an accumulation of these lifestyle factors. And by these lifestyle factors lead to other conditions like diabetes, high blood pressure, that then precipitates heart disease down the line. So you're absolutely right. Those are the main, and obviously, as always, prevention is always better than cure. It's always better to not have the condition than have to be treating the condition down the line. And then finally, in terms of volunteers, so we were very fortunate in the study I mentioned that we had 1,923 people across Yorkshire volunteer to take part in the study. We're always looking for more volunteers. We're doing many more studies. So, but that always goes out in a kind of coordinated fashion, because we have to be careful about how we're doing the consent and everything. But if there's one thing that we would always ask, and I'm sure Professor Gale would say the same, is that anyone that can contribute to the research, either by informing us, educating us, and that means sometimes giving your input to things like patient advisory groups, patient and participant in information groups, which we have, for example, I'm sure Professor Gale has as well, is really valuable, because actually everything we do has to benefit you. It's not just for the sake of doing it academically, but also when studies come out, if you and anyone you know can be encouraged to participate, that makes a massive difference. So we can actually generate the evidence to change policy and improve care going forwards.
Richard?
Yeah, I'd just like to echo that. So our volunteers are absolutely essential. We cannot do research without you for every stage of the research. Although it sounds so that we are generating the ideas of what we need to do for public good, actually the ideas come from you. So we undertook a piece of work recently asking what are the most important questions for eye health. Treating disorders early, better outcomes, and perhaps a few other things around diseases we can't treat at the moment. And that comes from you. It doesn't come from doctors, it comes from people informing us. And we have local groups who inform our particular research. We have people who very kindly offer their time to do that, very kindly offer to participate in research. Many thousands of individuals over the last 20 years or so have done that, and we can't do it without you. So in a way it's an opportunity to thank everybody for being involved.
Yeah, just on that, there has been a general reduction in the willingness of people to provide free labour in the last 4 or 5 years since COVID. Not, if I may say, in the demographic we have today. Usually it's a sort of younger groups are less willing to do that, and we see that in things like volunteering for studies. We see it in filling out forms like labour force surveys, census surveys and so on. People are just sick and tired of filling out forms and are less willing to do it. The consequences of that is that the routine data that we and other researchers depend on is getting worse in quality because it's getting less and less complete. So if you do get a survey that comes from a reputable organisation, that comes from Department of Health or for a census organisation, do please try to fill it in dutifully, because that data is very important. And on the volunteering thing, NIHR, who fund a lot of these surveys, a lot of these studies, we do have a clear emphasis on patient involvement. And it doesn't mean that you have to have the condition of interest. You may just be a member of the public who's interested in trying to get research which is applicable to the population that you live in. So if you're ever approached for that, do consider it seriously. Even if the study itself doesn't seem to apply directly to you, it's important to get patient and public voices. So that's just a plea of, yeah, please put your hand up and volunteer if you have that opportunity. So I think we've got time for a couple more questions. So we've just come over here, and then we take this question first because you're there with the microphone, and then we'll come over to this side.
Yeah, I've got maybe three questions for two. I've got three questions for the two doctors. For atrial fibrillation, is asthma a risk factor?
If we could maybe just pick one question if you could, and we'll come back to the other questions. So if you could just pick your favourite question, and we'll answer that one.
Is asthma a risk factor? And does drinking coffee mask symptoms of atrial fibrillation?
Okay, so asthma and coffee, and if we can come to this one. I'll come around. You can have my microphone, just a sec.
I think the lady was asking a question earlier about the vagus nerve and gut health having an effect on atrial fibrillation. It was also mentioned about the 70% rise in 20 years. Well, what do we attribute this to? And could it be something to do with perhaps ultra-processed foods, perhaps?
Yeah, so I guess in terms of both those questions, so asthma in itself is not a strong risk factor for atrial fibrillation compared to other lung conditions, though some of the treatments for asthma that affect some of the receptors can actually initiate an AF episode. So, you know, like the blue inhaler, the reliever, if you're having to take lots of it, it can precipitate heart rhythm abnormalities, one of which is atrial fibrillation. I don't generally find that asthma or coffee mask atrial fibrillation. If anything, they both precipitate, coffee especially precipitates arrhythmias. So one of the things, if someone comes to palpitations, it's one of the first things I ask in my clinic is, do you drink a lot of coffee? And often actually once that's dropped off, and I drink a lot of coffee as well, so that's not saying, you know, I drink too much coffee, especially with my two little children. So, but that can definitely precipitate abnormal heart rhythms. Regarding good point. I didn't mention the gut health thing and the kind of gut, heart and gut multi-system axis. I think we're becoming increasingly aware that what we eat has an impact on the health of multiple organs, not just directly from things like fat, etc., but also from inflammation. And why has AF become a lot more common in the last 20 years will be a number of factors. One is we're actually looking a bit more carefully for it because 20 years ago, we didn't have as many treatments as we have now, and actually its importance wasn't as quite well understood as it is now. Second, our population demographics have changed a little bit, so we have more older people now than we did 20 years ago. And if you look at the distribution of when people get AF, not many people get it when they're 18 or 25 or 30. It becomes much more common once you become 65, 70, 80, 90. Also, there are other factors that we know are associated with atrial fibrillation, like obesity, obstructive sleep apnea, levels of inflammation, which have become more common in our population over that time. And they won't just affect AF, they'll also affect age-related macular degeneration, they'll affect lots of other conditions. Regarding the idea about the ultra-processed foods, and that's obviously becoming increasingly aware in modern society and is being linked with the obesity epidemic as well as general ill health. I'm not an expert on that. I know it's something that is being looked at, and I'm sure anything such as ultra-processed food which increases inflammation in the gut will have an impact on ill health across multiple organs, including AF, though the exact numbers on that and how much one could change by stopping or reducing, I don't know.
Yeah, I'm going to answer this question, or the point that you make in a slightly roundabout way. The way that we are considering diseases, or I'm considering, and I'm sure it's the same with you now, is changing. So we think about macular degeneration, or often have thought about macular degeneration as a disorder affecting the eye. But we need to really think of this, because actually when we look at people with macular degeneration, there are associations with the gut biome, our biology within the gut. There are associations with blood disorders, hence the fantastic support we're getting for looking at these markers within the blood. And it can be associated with other disorders. Certain time, not everybody, but occasionally with kidney issues, etc., etc. So we're beginning to flip on the head the way we begin to think about macular degeneration as actually a systemic disorder which is manifesting in the eye. And I'll give you a parallel to that in your world. So when I was a young kid in short trousers 25 years ago, running around dealing with heart attacks, yes, I was doing it, we used to think about a heart attack as an isolated event. And then the conversation changed to ischemic heart disease. And then it changed further to cardiovascular disease. And what does that mean? It means it's a disorder of the entire body, but manifesting predominantly on that occasion in the heart. So I think we're learning from cardiovascular disorders, we're learning from many other disorders about how to think about disorders. And that's why this biology is really important. It's kind of a separate thing to what we're doing about early detection, but it's a really important aspect. And yes, the microbiome, the gut biome, your biology, does affect your risk of developing macular degeneration as well. It's fascinating.
Okay, so we're just going to finish there. So thank you very much for all of your questions. And thank you again, if you have a round of applause for our two speakers. And again, thank you for your questions. So I think, again, with these events, it's always nice to have the talks, but I think most of the good material comes from the questions. So thank you again. Apologies to those whose questions we didn't get around to. And again, so enjoy the rest of your day. Thank you very much.